The next speaker is Dr. Peter Carroll, presenting on AI of pathology specimens to predict outcome in prostate cancer. Dr. Carroll.
Thank you very much. Those were excellent talks, these last two talks. I'm going to go over some limitations of common risk assessment. We've heard the terms intermediate risk, high risk, but this spectrum disease, the current commonly used definitions are quite limited. So if you look at the NCCN definitions of disease risks, they're actually quite limited and they don't predict very well. And I would tell people you need to use a multivariable risk assessment model like CAPRA to get a better sense of what risk is really like. A lot of the low-risk patients are actually, a lot of the intermediate risk patients are actually low-risk patients. And in the era of targeted biopsy, the volume cutoffs in NCCN do not account for the modern biopsy sampling. We're seeing this now where lesion-directed biopsy alone, or in fact where the target is oversampled. And we see this a lot, and it overestimates risk. Gleason grade 1 is a cancer. Let's not dichotomize this disease. I have a letter coming out soon criticizing this movement towards renaming Gleason grade 1. How unfavorable is unfavorable intermediate risk cancer? We've seen a considerable grade migration over time. Right now, to get into this category, you really get into it not by PSA, you get into it by volume and grade. That's really defining modern risk assessment nowadays. It's not PSA or stage. Actually, only 4% of patients have all the features in the unfavorable intermediate risk category. And this is a surgical cohort at UCSF showing that, in fact, as we're moving towards more limited biopsies, we're moving towards identifying higher risk patients. But still in the unfavorable risk category, about 21% are really low risk tumors. Again, I'm just pointing out there's a lot of operational problems with current risk assessment. This is, I think, what you need to take away before I get into AI is this issue of histologic cell type. If your pathologists are not reporting histologic subtype of pattern 4, they need to be because it's very important and predictive. And we've talked about unfavorable histology, favorable histology, and it comes down to intraductal or large cribriform. A lot of people talk about cribriform, but small cribriform is borderline histology. So large cribriform intraductal, I think it's very important that your pathologists report on this. And again, this is a recent paper that came out recently by the Canary Group, which we're part of, looking at new definitions of histologic subtypes. And again, you see that this favorable and unfavorable category predicts for outcomes very, very well. So histologic subtype becomes very important. The other thing about histologic subtype, this is work from UCSF showing, again, borderline and favorable histology with regard to outcomes versus unfavorable. So the unfavorable histology really predicts for worse outcomes. The important thing, I think, to recognize is over here that these histologies correlate very well with genomic profiling. So in fact, if you can get them to report histologic subtype, you may not need to get genomic profiling. 80% of the time, an unfavorable histology will correlate with high genomic score. Emerging impact of AI, these were excellent presentations. I took down a lot of notes. We have a big interest in this. And in my department, we bought 2 scanners. And at UCSF, we've kept track of our outcomes very carefully. So we have these very large data sets. And I have 2 of these scanners scanning, one on single images and one on whole mounts. We've been doing whole mounts since 2015. We have a large category. I'll need to talk to Rakesh about this. So we have the whole mounts, and now we're scanning these patients, both whole mount and and just the slides and biopsies. The idea here is a centralized expertise, improve prediction, and potentially lower costs. By that I mean you'll obviate the need for ancillary testing like genomic profiling. This is just some work was done by one company in Johns Hopkins where they looked at, if you take pathologists nowadays, for expert pathologists, the predictive value for grade is about 90%. So 90% of the time, if you get expert pathologists, they'll agree on grading. But you go in the community, that agreement on grading falls to 50%. So in fact, in the community, you can have experts and you can have some that's not quite good. So what they did here is they trained on it. They had a training set of expert pathologists grade. They did developed an AI algorithm, and in fact, it worked quite well. Another thing is if you looked at, again, this is work, again, I've run many large data sets, and this is looking at the treatment of men who get radiation therapy in the US, low risk, intermediate, and high risk patients. And you'll see, even though there's a rationale for giving short-term hormonal therapy for intermediate risk and long-term hormonal therapy for high risk, these are the actual treatment here. But for low risk, we're seeing radiation and hormonal therapy about 1/3 of the time, even though there's no rationale for that. For intermediate risk, it's only 55%. For high risk, about 79%, not 100%. But hormonal therapy is very morbid, and certainly 2 years of hormonal therapy is very morbid, and the impact is underestimated on patients. So the idea here was to look at a model which predict, and this is our TERRA AI. This was developed by Felix Feng and others at UCSF, not me. And what they looked at is could they predict for the use of hormonal therapy in men who get radiation. So 2/3 of men with intermediate risk cancers don't benefit from it, and 1/3 of men with high risk cancers do not benefit from hormonal therapy. And they developed an algorithm which predict for response to hormonal therapy, and actually this is in NCCN guidelines right now. It made it explained in NCCN guidelines very rapidly. And you can see that if you have a low score, there's no difference between using hormonal therapy or not, but in fact, if you had higher scores, there was. So this is not, for some reason, not available in California or New York. I don't know the reasons for that, but I think it's a very useful tool. This is work done at Hopkins and Julia Ding, who now is at UCSF, and they looked at this whole issue of escaper and men on radical prostatectomy or escape. Now, these were all grade group 1 patients, and they applied the algorithm to this. So again, Hopkins has got expert pathologists, but their algorithm actually predicted for those men who would progress. Even though when they were grade group 1, this model predicted for it that this was a movement to grade group 2. Now at UCSF, I worked very hard to get these results, and they're not available, but we've done, we have a very large tissue biorepository. We've been using MRI for the last 20 years. We have whole mounts. And we've done 4 studies. So the outcomes, this is the one I was hoping to present, and I alerted your team that I might not get the data in time, and then I didn't. But I have about 1,500 patients who have 400 events, recurrent, after surgery events, that would be recurrence, metastases, and death. And this was 1,500 patients, about 7,000 images. These are very large data sets. And we've been able to move them, but they're very large data sets. The scanning has been complete. I'm just waiting the results. We have done a TMA. The results just came out on this. I have a TMA of 400 patients, again, with similar outcomes. Now, this was on a TMA, not the biopsy, but I can tell you that even though it's under review and I have a meeting set up when I get back, but the Artera biopsy score does predict for recurrence and development of metastases. FDA validation cohort's been done, and now we've chosen a large active surveillance cohort, really targeting adverse outcomes. So about 80% of on surveillance, of those who progress, about 80% do so marginally, about 20% do so significantly, and actually we picked a cohort of about 800 patients and we started to scan them. So in summary, I would tell people use refined risk models. I would go beyond NCCN. Do incorporate analysis of histologic subtypes. I think you need your pathologist to be doing that. It should be done routinely. It's important. And I think, and we're betting big on this because we own these scanners, we own these images, that AI is likely to transform the field of pathology, and actually I think radiology. If I was a medical student today, I'm not sure I would enter these fields because I think they're going to need fewer of them going forward. Thank you very much.